Thank you very much for the opportunity to be here. I just have to say that it's been a wonderful 2 days so far. I've really enjoyed my time here. In the clinics, it's been fantastic. I've learned so much in the clinics that I've had an opportunity to observe. And the hospital is a very rich environment for clinical care, obviously, but also in the discussions that we've had and even the discussions that we've had this morning and this afternoon, it's clearly a very rich environment for doing research as well. My passion has been glaucoma genetics research, and I'm going to tell you about a number of different studies that we've done, trying to get at the defining the role really for using genetics in glaucoma care and being able to include genetics as a routine test that we can use for patients with glaucoma. So these are just some disclosures that are not particularly relevant for today. So I wanted to start with this definition around personalized medicine. I'm sure this is familiar to all of you, but I think it's important to remember that personalized medicine uses an individual's genetic profile to guide the main principles of disease: prevention, diagnosis, and treatment. And it's important to know, of course, that genetic testing can help us define a diagnosis, which we've seen several examples of just in the last hour. It's important for clinical surveillance, tailoring the right kind of treatment plan to a patient, how often you're going to see that patient, and what you're going to treat that patient with. And then, of course, personalized medicine, understanding the genes that contribute to disease, can be the first step towards defining gene-based therapies, which can, actually be curative and potentially eradicate a disease. So personalized medicine as an approach is especially important for glaucoma. And here, I'm talking about all types of glaucoma, childhood glaucoma certainly, but also especially the common types of glaucoma that we encounter in our clinics. Here, effective therapy really depends on early detection and prevention of optic nerve damage. So many patients, unfortunately, are unaware of their disease until the optic nerve has been irreversibly damaged. We want to have a way that we can identify people who are at risk for developing glaucoma long before irreversible damage occurs, so that we can intervene at an appropriate time to prevent that. Genetic testing is something that can do that. Genetic testing can identify people with high disease risk so that you can initiate appropriate surveillance and treatment for those people, really tailored to their genetic risk. And I think another thing that's important, and I think it's important for glaucoma specialists to keep in mind. I think that geneticists know this, but genetic testing is really a one-time test. So in the glaucoma clinic, we're used to doing visual field tests 3 times a year, perhaps, or 2 times a year, OCTs 2 or 3 times a year, measuring intraocular pressure, of course, every time we see the patient. But genetic testing you do one time, ideally, if you pick the right approach. And so it's not something that has to be repeated every year. And it gives you a very good information about how somebody's risk has developed. Now, one thing that we've learned recently is that glaucoma overall is actually one of the most heritable of all human conditions. And so this is all human conditions. When we talk about things like asthma and cardiovascular disease, glaucoma is ranked up there at the very top of diseases in terms of its heritability. So we know that there are certainly genes, and important genes, that underlie glaucoma pathogenesis. When we think about glaucoma genetics, I think it's useful to think about childhood glaucoma separately from adult onset glaucoma, because they're inherited differently. And the methods that we use to discover the genes that underlie these conditions are different. So, for example, early onset diseases like congenital glaucoma, juvenile open-angle glaucoma, anterior segment dysgenesis syndromes, these, in general, are caused by rare mutations, and the rare mutations can have very large causative effects. So you have one of these mutations, you have a disease. You have a PAX6 mutation, you have a disease. Because they are large effects, they tend to occur in families. Autosomal dominant, and of course here, in this country where there's a lot of consanguinity, autosomal recessive. Traditionally, these kinds of genes were found using genetic linkage studies, and now, of course, more recently, using next generation sequencing, exome sequencing, and now even whole genome sequencing. So in contrast, the adult onset diseases, primary open-angle glaucoma, exfoliation glaucoma, angle closure glaucoma, these are inherited as complex traits, multifactorial traits, a little bit like the discussion we had around keratoconus. These are not caused by individual single genes with large effects. Instead, these are associated with common DNA variants that individually each have a little effect, but in aggregate, many of them together can reach a disease threshold. We find these using association studies like genome-wide association studies, and we have hundreds of genes and loci that are associated with these conditions. So genetic testing is useful for both early onset and adult onset. I'm going to talk about early onset first. Now, as we've just witnessed and we've discussed, genetic testing is very useful for families with childhood glaucoma. Simply put, by doing genetic testing in a family, we can identify the people in the family who are mutation carriers. And that actually, for some of these families, perhaps not as much for the congenital glaucoma ones where it may be very obvious from a physical exam, but for the juvenile open-angle glaucoma families where it's not known which of the children in the family carries a mutation and actually needs to be followed carefully, genetic testing is very important for those families. It allows for tailored surveillance and treatment of the children who actually have the mutation and reassurance for the children who don't. It can also, of course, inform genetic counseling, autosomal recessive versus autosomal dominant inheritance, and it provides a molecular diagnosis. And as we begin to move towards gene-based therapies for glaucoma, a molecular diagnosis is, of course, absolutely important for that. We aren't as advanced in glaucoma in terms of gene-based therapies as in the inherited retinal degenerations, which are, of course, leading the way in this area. But there are a couple of things that suggest that the gene-based therapies are emerging for glaucoma. Recently, there's been a study done by our colleagues in Iowa who have shown that for patients with myocilin mutations, that a particular MIGS procedure, the gonio-assisted transluminal trabeculotomy, may be particularly effective. And so you would want to know that these juvenile open-angle glaucoma patients have myocilin mutations if you're considering using that procedure. Also, in preclinical studies, using a CRISPR-Cas9 gene editing approach, ablation of mycelium can actually be protective against disease development in mice that carry a mutation. And this is then suggesting that this kind of approach could also be useful for humans who carry these mutations. So as you know, because you do a lot of genetic testing here, which is really great, the genetic testing begins with a referral from a healthcare provider. We, in the United States, we use both blood and saliva collected from the patient. We do a DNA test, which I'll talk about in a moment. We analyze the DNA, write a report, give the report back to the provider, which then allows for appropriate follow-up for the patient. Now, I think that, we've talked a little bit this morning or this afternoon already about the genetic testing approach. I think it's important to think about this. Historically, we use single gene Sanger sequencing for pretty much all the genetic testing that we did. But of course, as techniques advanced and we could do gene panel tests for a particular disease, that became more efficient than screening a gene, going back and screening another gene, and so forth until you find the right one. Advances even now over the panel testing is whole exome sequencing, and we're beginning to embark on an era when we're considering moving from whole exome sequencing to routinely using whole genome sequencing, which really gives you a comprehensive set of genetic variants that can be causing a disease. So I think in addition to what method of testing to use is also consideration of who to test. And I put up here just an example, say, of if you were testing, for a group of patients potentially for aniridia, you might just limit your testing to patients who have clinical features of aniridia and say, I'm going to test people with aniridia for PAX6. But we know that there's a lot of variable expressivity for PAX6 mutations, and that by doing that, you might miss a lot of aniridics that don't have the classical phenotype, and therefore they're really anterior segment dysgenesis patients. But even taking then another step further, it may be that the best approach is to just test any patient with a childhood glaucoma, because unless it's trauma or some toxin-related disease, it's likely to be inherited. And by testing for it, then you will find a full range of mutations in genes that can be causative. So I think increasingly the field is moving towards a broader approach, not only with regard to phenotype, but also with the approach wild type in terms of its secretion. So we came up with this little cartoon that suggested that the more secreted a protein was, the more normal the patient was, at least with regard to glaucoma. We still don't know 100% what's going on here, but one thing we do know is that EFMP1 is clearly associated with glaucoma. The second gene that we have found doing a similar kind of approach, but with very different families, these three little families shown here, is thrombospondin, also another extracellular matrix protein that is secreted. And here, using three families from very different ethnic backgrounds, European Caucasian, an Indian mixed family from continental India, and an African family, we found the same mutation at the same amino acid residue, suggesting the importance of that particular missense change. I'm not going to take you through all the follow-up studies that we did here, but we made a mouse with the mutation and showed that the mouse also had accumulation of the protein and had elevated intraocular pressure. So I show you these to emphasize that using these kinds of approaches now, we can find new genes for childhood glaucoma, and that this eventually will help our diagnostic yield for these individuals. Okay, I'm going to switch now and spend the rest of the time talking about adult onset glaucoma. And just to remember here that these conditions are complex and they're associated with common DNA variants that we find doing genome-wide association studies. So a genome-wide association study is really just a comparison of allele frequencies for these common variants between cases and controls. We have to use very large numbers of cases and controls to detect meaningful differences in these allele frequencies because, as you recall, they have small effects, which means that the difference between cases and controls is not huge. If it was huge, it would be a childhood glaucoma gene. So to find these adult onset glaucoma genes, we have to collaborate to get the kinds of numbers that we need to find the genes that contribute to these conditions. So the first collaboration that we formed in this regard was called the Neighborhood Consortium for Glaucoma Genetics. And here, at all of the sites shown on this map of the United States with the little red stars, we had collaborators who contributed cases and controls with a harmonized case definition to a larger group that we could then use for the genome-wide association study. So in total, we collected nearly 4,000 cases and about 33,000 controls. We were able to do a genome-wide association study here, and at the time when we did this almost 10 years ago now, we found 3 new loci for primary open-angle glaucoma, which was a great advance at the time, good enough to be published in Nature Genetics, but still only explained a small percentage of the overall heritability of primary open-angle glaucoma. So to make further progress, we joined forces with our international colleagues, who then contributed the cohorts shown here on this world map. This included a number of European Caucasians from North America and also, of course, Europe, a number of Asian cohorts, and then also some cohorts from Africa. Altogether here now, we dramatically increased the number of cases and controls that we had to about 40,000 cases and nearly 350,000 controls. So a lot more statistical power to find these variants with these little differences between cases and controls. This is the results of that genome-wide association study. This is the so-called Manhattan plot, named after the skyscrapers in New York City. And here, the genetic variant is plotted according to its location, its chromosomal location, starting at the tip of the first chromosome and working all the way down through the end of the X chromosome. And then the negative log of the p-value is plotted on the y-axis. So you can see here that there are many, many statistically significantly associated genetic variants. We had 127 total from this study, where we had only had 3 before, a few years before. One thing that we learned right away there's a pathway that includes the TEC, angiopoietin 1, angiopoietin 2, that cause congenital glaucoma. And it turns out that common variants that are near those genes, rather than causing congenital glaucoma, cause adult onset glaucoma. So this is an interesting relationship between early onset glaucoma and late onset glaucoma. And it's something that we need to focus on more in the future. Now, when it comes to genetic testing for adult onset glaucoma, you have to consider how challenging it could be to use all of those genetic variants in that entire genome-wide association study for genetic testing. How does somebody do that? Well, first of all, it's important to remember, as I've said, that unlike the early onset glaucoma mutations, where a single mutation is enough to tip the balance from health to disease, for the adult onset variants, each one has a small incremental effect on disease, but in aggregate, the disease threshold is reached. So it doesn't make sense to test each one of those 127 variants one by one, because one by one, they don't really do very much. But what we need to do is test them all together, because all together, then, there's a relationship with disease. So fortunately, methods have been developed to allow this kind of testing of many, many variants in a single person. And this is called the polygenic risk score. So to calculate a polygenic risk score, you start with a very well-powered genome-wide association study, like I just showed you. You define the association model for each variant in that GWAS, assigning a kind of an effect weight to each one of the variants that you're interested in. And then you simply add up all of these weighted SNPs or weighted variants in an individual to find out how many they have. Some people are going to have a lot, some people are going to have a few, most people are going to have an average number. Each person then is percentiled against their population of origin. And the assumption is that people who are at the very extreme of the polygenic risk score, the people who have many, many variants, way more variants than anybody else, those people who are in the 90th percentile of the polygenic risk score distribution, these are the people with the highest risk for glaucoma. While the people who are in the lowest distribution, the people who have the least number of variants in the lowest 10th percentile, those people have the lowest risk of glaucoma. Now, we've been able to do this for about 5 years, and we've learned quite a bit about the risk of having a high polygenic risk score in primary open-angle glaucoma. First of all, people with high polygenic risk in open-angle glaucoma have an earlier age of diagnosis, about 10 years earlier than people with low risk. That may not sound a lot, but it's a lot when you're thinking about somebody developing disease at 50 instead of 60. People with the highest genetic risk have a higher intraocular pressure compared to the lowest. They have thinner retinal nerve fiber layers on OCT. They have an increased likelihood of progression. So, progression rates vary in glaucoma. People with the highest polygenic risk progress most rapidly. And because of all of these factors, they have a greater need for surgical intervention. They don't do as well on medicines alone. They need an operation. In addition, using the OATS study, we found that patients with higher polygenic risk scores and high intraocular pressure, so people that qualify as ocular hypertensives, that ocular hypertensives with high polygenic risk scores are more likely to convert to optic nerve disease than patients with low polygenic risk scores and high pressures. So putting all this together, we can begin to think about how we would use a glaucoma polygenic risk score in clinical management. So you might think about a patient who's a glaucoma suspect. Perhaps they have high intraocular pressure, but no optic nerve disease. Or perhaps they have, a borderline cup to disc ratio. If you do their polygenic risk score, they have low or intermediate score, well, you might consider they're not going to be somebody who's likely to progress. You could take perhaps a less aggressive approach with that patient. Maybe not have them come back 3 times a year or twice a year, maybe once a year or every other year. On the other hand, though, a glaucoma suspect who has a high polygenic risk score in the 90th percentile or above, well, that's somebody who's likely to have more severe disease. And perhaps you would want to increase surveillance of that patient. Maybe see them a little more frequently, especially now that you've freed up your clinic by getting rid of those low ones. And perhaps initiate earlier or maybe even prophylactic treatment for those people. These are the people you really want to catch. They're suspects. They don't have disease yet. If you could initiate treatment earlier, that's very helpful for them. Similarly, for patients who already have glaucoma and they have low or intermediate scores, well, you might consider your standard of care. They are likely to be glaucoma patients who don't progress rapidly, may not need surgical intervention, but at least, given that they already have disease, you probably should follow them normally. But those glaucoma patients with high polygenic risk scores, they need more frequent surveillance. They might need earlier treatment. So, in addition to using polygenic risk scores to assess disease severity in a glaucoma population for risk stratification, we also wanted to ask the question, how about using polygenic risk score for glaucoma screening? A huge problem in glaucoma. So many people in a glaucoma population or in a population at risk are unaware that they have glaucoma. The undiagnosis rate is very high. Can we use polygenic risk screening as a way to find people with glaucoma? Can polygenic risk score testing identify a high risk group for targeted screening where you could make the argument that you could make OCT screening or intraocular pressure screening more feasible in this smaller group rather than, say, considering applying it to the entire population? So we did the following study. We took advantage of the fact that at my institution, Mass General Brigham, has a very large biobank, and my colleague, Dr. Lou Pasquale, at Mount Sinai, also they have a very large biobank. So what these biobanks are people who have volunteered, who have electronic health records available, but also have given blood samples for genotyping. So the genotype data is available, and we could simply calculate a polygenic risk score based on that data for 90,000 people, half of them at Mount General Brigham, the other half in New York at Mount Sinai. After calculating the polygenic risk score, we invited people who were in the very top of the distribution and people who were in the very bottom of the distribution to come in for an exam. And we did this for a couple of reasons. First of all, we wanted to know what they had. Did they have glaucoma or not? How accurate is our polygenic risk score at detecting glaucoma? But also, we wanted to know, since there are so many undiagnosed people with glaucoma, does the polygenic risk score capture those people as well? So they came in for exam. We did a full clinical exam in our glaucoma clinics at both sites and calculated the prevalence for glaucoma in both the top and the bottom decile. And what we found, you can see right here on this slide, is that in the top decile, the people who are in the 90th percentile and above had a glaucoma prevalence of 20% compared to 4% in the bottom decile. So indeed, the polygenic risk score can find people with glaucoma and can identify a high-risk group for targeted screening. Importantly, what we found is that of the people that we diagnosed with glaucoma in this study, 50% of them were previously undiagnosed. So the only reason these people were diagnosed with glaucoma is because we calculated their polygenic risk score, they enrolled in our study, they came in for an exam, and we made the diagnosis. So I want to tell you about one of these patients that we saw. This is a 66-year-old male. He had a family history of glaucoma, but he thought it was only in his father's brothers. So he didn't think it applied to him. He had decreased vision, but he thought that was due to cataracts. He didn't think he had any other problem. On examination, indeed, his vision was decreased, 20/50 on the right, 20/60 on the left. And alarmingly, his intraocular pressures were 30 in the right eye and 33 in the left. He had never had an ophthalmology examination and came in to see us because we calculated his polygenic risk score. These were his visual fields, which are tragic. And his polygenic risk score is that he was in the 99th percentile. So imagine if we had this test 30 years ago, and we could have tested him 30 years ago before he developed this kind of damage to his visual fields, he could have known about his high genetic risk, and we could have potentially treated him much earlier in his disease course and prevented this kind of damage. So I want to tell you about two more things, and then we're almost done. I want to tell you that the polygenic risk score also modifies other things. And so we had talked about this just briefly a little bit when we were talking about CYP1B1, but this is the data from our paper in 2021 that shows that high polygenic risk can modify the severity of, say, a mutation in myocilin, a gene that we've heard about a fair amount today that causes juvenile open-angle glaucoma. People who have the myocilin mutation and a high polygenic risk score have more severe disease than people who just have the myocilin mutation. And because of all of this, we are rolling out a new test for genetic testing that we're calling that's called the blended exome genome test. And this will allow us in the clinic for a relatively low fee of about $100 American a person to test not only for childhood glaucoma genes from the exome content, so things like CYP1B1 and myocilin, but also at the same time to be able to calculate a polygenic risk score from the whole genome component. And so by putting these two things together, we think we'll be able to get a good estimate of genetic risk for patients that come into our clinic. So just to summarize then, we have 12 genes for childhood glaucoma, which is not a lot. We have hundreds of genetic risk factors for primary open-angle glaucoma, which is a lot, but still is a lot to work with. Genetic testing for childhood disease identifies mutation carriers, allowing for risk-appropriate surveillance and treatment, and polygenic risk scores based on genome-wide association studies can be used for primary open-angle glaucoma risk stratification and may be useful for population screening. There's a lot that we have to do in this field of glaucoma genetics. We need a lot more genes, I think, for childhood glaucoma, or at least a much better understanding of the genetic underpinnings of childhood glaucoma. We need to have a better idea about gene function and disease mechanisms for all the glaucoma genes. We really just understand a few of them. We need to do more functional studies. We need to know more about how polygenic risk scores influence outcomes and whether, in fact, doing a screening test that would be polygenic risk score first and then perhaps other clinical testing after, is that cost effective? But things are going in the right direction. We have larger data sets, newer, important analytical methods, faster, less expensive methods for DNA and RNA sequencing. We have other kinds of data coming on board, proteomics, metabolomics, epigenetics data. And the field is very collaborative, which I think is really an exciting opportunity for everyone to be involved in this kind of work. So I just want to acknowledge my collaborators. These are all the people in the original Neighborhood Consortium, which has been a fantastic group of people. This is the International Glaucoma Genetics Consortium, another really great group of people. This is the team that did the in-person polygenic risk score study at Mount Sinai and at our Mass General Brigham. And then these are other collaborators and other projects that we're involved in, especially the Filipino group that worked on the EFEMP1. So thanks very much. I hope we have some questions.
Thank you so much. Thank you so much, Dr. Wiggs. I mean, this is great talk and huge efforts, actually. We'll open the door for questions. Any questions?
Thank you, Professor Wiggs. Very, very interesting. So with this approach with polygenic risk scores, you can identify the people who are likely to have a high risk of glaucoma. On the flip side, how many people are you likely to miss in the community who might have glaucoma? So what's the specificity of this approach?
Yeah, it's an excellent question. I didn't spend, we have more data from our in-person study that helps address this. And what I can tell you is that in the bottom 10%, we have 6 people with glaucoma. So those are the people we would miss. We want to look at those people more carefully, to get a sense of what are we missing. We've looked at it a little bit. These are a couple of those cases are people who had perhaps damage because they were on steroids, had a steroid-induced glaucoma. There are a couple patients with diabetes, perhaps also maybe that lowers the threshold a little bit. So it's an important question, but it's not a lot. And on the other hand, we capture a lot of people in the top who didn't know they had disease and have severe disease.
Thanks for a great talk. So I have 2 questions. One is, do these polygenic risk scores vary by ethnicity?
Yes.
They do? Okay.
Yes, and that's a very important question. So the polygenic risk score is really only as good as the genome-wide association study that's used to support it. Now, the one that we've been using is based on that cross-ancestry GWAS that I showed, the big international study. So it had excellent representation, as these studies always do, of European Caucasians. But also this study had very good representation of Africans and Asians, which is about as good as we can do in this current time. But we do need to always keep in mind that in a specific population, a polygenic risk score based on a GWAS carried out in a different population may not work as well. One other thing I would say is that in our cross-ancestry GWAS, we looked at correlation of effect sizes for individual genetic variants in different ancestral groups to see how similar they were. So the more similar they are, then the better polygenic risk score is going to work across all those groups. And interestingly, most of the variants have very similar effect sizes, even, in the very diverse groups that we were looking at. But there are some that don't. And so I think that's the unknown is how do you account, maybe those are critically important, the ones that don't have the same effect sizes. So those are things that we need to look at in the future.
And the second question was, you think by adding some clinical factors like an oculomics approach to the PRS score would increase the sensitivity of the test?
Yeah, absolutely is true. And I think that is true, but the point here is that we want to develop a test that is cheap and can be employed at population scale. So OCT is a great test. You're not going to miss very many people with glaucoma by doing OCTs on everybody, but you can't do that at population scale. In fact, you can't even do intraocular pressure measurement at population scale and get meaningful information. So our idea here is that you flip that around. You do polygenic risk score testing first, identify a high-risk group, and then in the high-risk group, you throw all the clinical information. So you do the OCT, you do the IOP, you do visual fields, and then put that together with the polygenic risk score in the high-risk group. So, we're kind of liberal with our high-risk group. We're not saying it's 99%. We're saying it's 90% and above. And I can tell you that after 90%, the prevalence of glaucoma just drops like a rock. So in the top decile, we really capture most of the cases.
Any question? If there is no question, I will ask.
Okay.
So, this is really great. GWAS study usually depends also on how clean and well-defined your controls are, right? So I've seen like many of the GWAS centers, right? How did you define your controls in these studies? They first they affect the rate the effect size, right? Because if you find something that is your controls are contaminated with cases, then that will undermine your efforts, right?
Absolutely. So, the best possible approach is to be able to use clinically examined cases and controls so that you really know that your controls are truly controls and correct for differences in age and ethnicity that can also affect the status. That's not possible in every population. So in our neighborhood study, which, in retrospect was a relatively small study, still yielded 3 really important loci, probably because it was so cleanly defined, because we clinically examined everybody. When you get into much larger data sets, it becomes impossible to do that. 350,000 people. So many of those controls are people that didn't have a self-report of glaucoma or had an eye exam and never had a diagnosis of glaucoma, but we don't have all the clinical data on those people. So there's potential for misclassification there, which does limit the power in a GWAS, but the idea and hope is that you make up for that loss of power by increasing the sample size, especially in the cases, and all the cases are known cases.
Okay, great. So also there is, you follow the forward approach where you calculate the polygenic risk score, then you try to see if they are affected, right? Have you tried to do like the Mendelian randomization way where you intervene, do the surgery, do everything, then go back and calculate the polygenic risk score and see how is the utility?
Yeah, so we've done that too. And that's where a lot of the, the beginning sort of studies that I showed you, that's how, we knew that people had high polygenic risk, and we, did clinical examination, or, age of diagnosis and things like that. And that's very good for risk stratification. It's very helpful for risk stratification. It's not so helpful for screening because you don't have that information in screening. So.
Any question?
Thank you very much for a wonderful lecture. I have a question that doesn't have much to do with this lecture, but I want to hear your insights about it. We have we have a lot of autosomal recessive diseases, and one of them is the autosomal recessive BEST prophenopathy. And those patients have generally tend to be hyperopic when they're homozygous, not necessarily when they're, compound heterozygous, but and 51% in a study that I have of patients, a lot of patients. So we have basically more than almost 50 plus patients, okay, from 24 families, 28 families. So 51% of them have narrow angle glaucoma. And some of them have narrow angles when when they're young, and then it develops into a full-blown narrow angle glaucoma. And so I want to hear your, if you have any idea, what is it about the BEST gene that predisposes people to narrow angle glaucoma? Is it just the fact that they're a little hypermetropic, and maybe it is like a dimensional thing that makes them exposed to this? And I suppose that not every hyperop ends up with narrow angle glaucoma anyway, so there must be something in the BEST gene. So do you have an idea about what is it in the gene that makes that?
Yeah, I don't have a great answer for that. I do know that one of the BEST gene families is in one of the loci for POEG, and that might, it's not the one that you're talking about though, it's one of the other ones. And so that, there might be something about the biology of the genes in that family that also contribute to some anterior segment dysgenesis or to trabecular meshwork dysfunction. I think it'd be an interesting thing to look at more in the future. One thing also I'll add is that the two new genes for childhood glaucoma that we have found in the last couple of years, they're both extracellular matrix proteins. And so there's a lot of proteins in the extracellular matrix. So, I think that's, when we have a family of proteins or there's one member of a family or a pathway that looks, that contributes to disease, then that's a logical place to start to search for new genes. In other words, proteins that interact with that, in the same family with that, or function in the same part of the eye. So that's been our thinking along those lines. Yeah.
Thank you.
Thank you. Yeah.
Thank you.
Any more questions? So final question.
Final question. Okay.
I guess. So talking about the budget
Budget.
for such studies, for example, the neighborhood, just tell us more about the budget.
Okay, the budgets are high. All of these studies that we've done have been supported by the National Eye Institute, from the National Institutes of Health, from the government for the US, which is currently shut down. So we, at the moment, have no money. But the costs of doing the projects are high. I mean, our grants run about $500,000 US a year. A lot of that involves salaries for people, to do the work. I mean, bioinformaticists are expensive. Genetic epidemiologists are expensive. Collecting patients from the clinic is expensive because you need to be able to pay for those clinical exams. The actual genotyping costs and sequencing costs are surprisingly a low fraction of all of that. And those costs are steadily decreasing. And as I mentioned to you earlier today and also in the talk, this blended exome genome test, which gives you a pretty good comprehensive set of variants, is going to cost now around $100. That's really very reasonable. So I think that this kind of approach is going to become financially more manageable going forward, but you're never going to get away from the people costs, which are so incredibly important, to actually do the work, as you know. Thanks.
Thank you.